So far we've heard some really great talks yesterday and today on history, epidemiology, virology, lessons learned, prediction, most recently on impact on minorities. And now we're going to turn to probably one of the most, as you can imagine, critical aspects of the story and the future is really prevention, preparedness, and communication. We've already heard some folks talk about that. Dr. Frieden talked about global initiatives. We heard in the last session about the importance of communication and vaccination. So we're at this critical topic, and we're really fortunate to have really some great speakers representing different aspects of this issue. And I will give brief introductions for those folks so we can get going. Our first speaker is Dr. David Weber. He will address hospital preparedness and responses in the flu epidemic. Dr. Weber is professor of medicine and pediatrics in the UNC School of Medicine, as well as professor of epidemiology in the School of Public Health. He also is associate chief medical officer for UNC Hospitals and medical director of the departments of hospital epidemiology with infection prevention and occupational health for the UNC hospitals. Dr. Weber's research has ranged from epidemiology of healthcare-associated infections to new and emerging infectious diseases such as novel influenza, SARS, MERS, Ebola, response to biothreats, non-tuberculosis mycobacteria, norovirus, control of drug-resistant pathogens, immunization practices to zoonotic diseases, and epidemiology of tuberculosis. So he's exactly the awesome person we want to talk about these topics. Our second speaker is Dr. Bridget Kelly. She will focus on best communication practices during outbreaks. Dr. Kelly is a senior health communication research specialist and program manager for the science and public sphere at Research Triangle RTI International's Center for Communication Research. During the 2009 H1N1 epidemic, Dr. Kelly led a rapid response study of the CDC's H1N1 web pages and an evaluation of CDC's pandemic preparedness communication efforts. More recently, she's published peer-reviewed articles on communication during outbreaks of Ebola and the outbreak of the Zika virus. Finally, our last speaker will be Dr. Zach Moore, who will share local health perspectives on preparedness and responses to flu and other emerging infection epidemics. Dr. Moore is the state epidemiologist and chief of the epidemiology section with the North Carolina Division of Public Health. He began working with the North Carolina Division of Public Health in 2006 as an officer with the CDC's Epidemic Intelligence Service. Before that, Dr. Moore coordinated state influenza surveillance and served as an influenza subject matter expert for the state. So please join me in welcoming our first speaker, Dr. Weber.
Thank you very much. It's a great pleasure to be here and to be talking to you about pandemic influenza. And my talk is really going to bring it down to the local level. Well, I should say we've had a great deal of experience in hospital preparedness for new and emerging diseases, including pandemic flu, outbreaks and pandemics that have led to our current policies and plans include smallpox back in 2011 related to the 9/11 attack, SARS in 2003, pandemic influenza 2009, more recently Ebola, MERS, and then Zika. So we've had a number of diseases that affected the U.S. more than others, all of which we spent much time, thousands of person hours planning for with multidisciplinary teams that have led to our general preparedness plans. So we do not have a specific influenza preparedness plan per se. We, of course, base our plans on guidance from the Centers for Disease Control and public health authorities, and certainly we've planned for some of the potentially emerging new influenza viruses, H7N9 and H5N1. At UNC, we have a general disaster plan. Within that disaster plan is nestled an incident command system, but this is for many different disasters, including fires, explosions, shooter incidents, et cetera. Within that is a communicable disease plan, and it's really broken down into highly communicable contact-transmitted diseases, Ebola, Marburg, Lassa, highly communicable respiratory transmitted diseases like SARS, MARS, avian influenza, and the pandemic influenza plan's really nestled into that highly communicable respiratory transmitted plan. Well, let me tell you some of our experience that's led to what we do, and Zach Moore, our state epidemiologist, is certainly familiar with this. Back in 2003, we had an index case who developed SARS after being in Toronto. He worked at UNC, but not anywhere in the health area. He was actually in the air conditioning area. This was recognized very slowly, despite multiple visits to a local physician. Ultimately, there were many exposures there at both in Durham County, Orange County, and Wake County, and we were very involved in that. In particular, the people, roughly 250 people who worked with him, were very concerned about acquiring SARS. This led to our response, and just to show you how our planning works, we set this up at the Horace Williams Airport in the parking lot. This was done in 12 hours between 6 p.m. one day and 6 a.m. another day. Multiple tents were there. There was a triage tent. There were multiple tents to evaluate the 250 people, and then there was a fully equipped medical tent. Notice this was sort of in the warmer weather, as often case here. So the tents were air-conditioned with portable large air conditioning. You don't really get a sense of the size there, but here was our initial tent. You can see we had a full medical tent that had lab capability and x-ray capability. And for people who had not been trained on personal protective equipment to protect our healthcare personnel, we trained them right on site. All of this was set up within 12 hours. Of course, we do base, there's excellent guidance from Health and Human Services, and CDC is listed here, and our plans are consistent with theirs, but their plans are not detailed enough on the local level to handle all the little local issues that we have to detail with. And you can see here the metrics and preparedness frameworks from CDC, and of course, the two-dimensional aspects. And this is particularly important because prior to 2009, the WHO and CDC guidance on how to respond to a pandemic only looked at transmission. So the more transmission led to doing this, but it didn't include virulence. And so as it turned out, 2009, we had a new strain, highly transmissible, but not particularly virulent. Of course, the concerns are we'll develop both a strain like 1918 that's both transmissible and virulent. So in terms of CDC pandemic guidance, the local medical care countermeasures advise healthcare providers statewide to promptly diagnose influenza and promptly treat people based on current recommendations, implement infection control. There's nothing new about any of these viruses. In the hospital, we know how to protect our healthcare personnel. We know how to protect our patients. We know how to protect the visitors. There are only a few routes of transmission, and we're well experienced with influenza. Obviously, we rely on the state and the CDC for the national perspective and for the larger surveillance. We do have guidance documents. We are in constant communication with the state and with the CDC. We monitor medical surge trends at our hospital on a daily basis. We know exactly how many beds we have, where we have them, what our needs are. We replenish our stockpiles there, and of course, there's a federal stockpile, and Dr. Moore may talk more about that. Then other things, recognition interval. Obviously, the key here, really the two aspects we think are the most critical. One is when we first see the patient, that we protect our healthcare personnel and treat the patient appropriately there, so proper signage, which I'll talk about, and proper recognition, and then protecting our healthcare personnel is there. Obviously, CDC provides assistance with guidelines on surge capacity strategies and has their stockpile of masks and gowns and ventilators there. So let me tell you, we do this all the time. Flu occurs every year. Here are the numbers there. We have up to 10% of the population gets infected. We have 10 to 50,000 deaths. We're on the higher side this year, up to 700,000 hospitalizations, and up to 35 million cases, so we're well experienced. What's happening already this year with UNC? We've had roughly 1,700 positive influenza tests. Not all our patients get tested. This is a minimum count, and there have been some shortages of kits. And you notice that this year is a typical flu year. Unfortunately, we've had 8 deaths. Anybody can get influenza. Of those 8 deaths, 3 of them were perfectly healthy individuals. Well, certain people with underlying diseases are at higher risk. Anybody can get it, and there are more healthy people than there are people with underlying diseases. So in any given year, a substantial number of people who are healthy die, which is why everyone should get influenza vaccine. And as you can see here, here are the different years. By the way, here's this year in green, showing you how big a peak we've had this year. And you'll notice that at the very end here, we're tailing back up. So we're not diminishing, we're tailing back up. This is a shift from the A strain earlier in the year to a B strain right now, and we monitor this each year. We do lots of other monitoring, including number of patients seen in the ED, what specific viruses, what part of the hospital they're in, and we send that surveillance system and notes around to all her physicians weekly. So what are the critical issues for the hospital? Well, number one is surge capacity. Maintaining adequate staffing, so it's not only that we worry about all the patients we have to take care of, but what do we do if all our staff are ill? And then provision of essential services and supplies. Additional issues are surveillance, early recognition and triage, diagnosis, protecting personnel, occupational health, stockpile personal protective equipment, how we triage if there are limited supplies, beds, ventilators, and maintaining security. So surge capacity. Well, we have an infectious disease clinic that was specifically built to help with outpatients. Every room in our infectious disease clinic meets all the CDC requirements for airborne isolation. We can use medical tents, as I've already showed you, and those are actually, we have them on call if we need them. And we already have plans about how we could take over other buildings to increase our outpatient demands, such as Hillsborough Hospital, family practice, and others. The big way we'll manage surge capacity is by turning off all elective surgery. That frees up all those ventilators. We can use our very large recovery room, which has 50 beds. That could be, and is equipped for every bed, to be an ICU. So that is part of managing that. Or we can convert entire hospitals or floors to isolation units, and we have plans to do that. In terms of healthcare personnel, we have the explicit statement that all our personnel are expected to provide essential services. We can increase our shifts. The plan would be to 12-hour shifts. We do need to make sure our personnel are properly rested. We have hotels that we already have contracts with, so they won't have to go home. They could stay at the hotels if they want. We have plans for flexible shifting of personnel and, as I said, provision for sleeping locations. We have plans to use retired healthcare personnel. It would require a waiver of some of the legal requirements there, but we have a number of retired individuals. We could use students for some of these activities, and we could use healthcare personnel working in our other affairs, so meaning nursing school, dental school, school of public health, pharmacy. So we could use many of the healthcare personnel that spend most of their time not in the hospital. And the hospital has already agreed and has written into its language appropriately that we would cover any malpractice costs and workers' compensation for any of those people who came to work with us. And those plans have already been established. Maintaining adequate supplies. We have a 6-month supply at UNC hospitals of personal protective equipment, gowns, masks, and gloves, since many of them come from foreign sources. I should say that's under normal usage. Under increased usage, that would be much smaller. We potentially could use university supplies if the university closes, and we have management plans with the university. If they close dorms and cafeterias, we could use their food and resources. We have a monitoring system to look at those supply shortages. Ventilators, we could use the ones that we'd normally use on elective patients there, and we have plans to stockpile other essential things such as medical gases. Ultimately, of course, we would have the federal stockpile to obtain additional material from if we needed. And we have plans for triaging critical supplies. And this is based on conversations with the UNC Hospital Ethics Committee, how we would do that. It's not simple. There's no simple way, obviously, to make those ethical decisions. In general, within disaster planning, the person who has the best survival is the one who would get the shortage when there's shortages. But that's already in the works. Other solutions in terms of surveillance, obviously we follow North Carolina, CDC for larger surveillance. We monitor influenza-like illness in our emergency department and all of our clinics. We monitor all the infected patients on a daily basis. We monitor hospital admissions and ICU admissions and deaths. All of those are being monitored all the time. We monitor the rate of illness among our medical personnel. We do monitor all our critical medications and the personnel for shortages. So all of these are monitored all the time anyway. Doing this during a pandemic would not be difficult. One of the critical points is early detection and triage, and before the patient actually enters, so they're not actually infecting our patients, our personnel, as well as patients and visitors. We have signs, I'll show you some of them. We would restrict the hospital to certain visitors. Currently, we're still restricting patients 11 and younger because they can't contain secretions and they excrete influenza virus for larger amounts and longer periods of time. We would set up triage stations so people would be screened before they actually entered the hospital. We have in our electronic system a little thing which is turned off, but we could turn on, such as at every single point that they had contact with the healthcare system, they would be screened for illness. We use that with Ebola. Some people got screened 4 or 5 times during a single visit because as they came into the hospital, they were screened. When they went to radiology, they were screened. When they went to the floor, they were screened. But redundancy is built in, and we could turn that on instantaneously. And we would restrict visitors, and those that came in, we could clearly screen before they came in. We already labeled the patient's charts with appropriate isolation. That's right at the flag, so everyone could see that. And if needed, we could put hard stops on the medical records to make sure people are screened before actually any other activities are done. These are just some of our alert signs, just some of the ones we use routinely for cough etiquette, and you heard Dr. Frieden talk about that, having the patient gown and mask when they come in, flu alerts, and then these are our signs that go on the door to alert our personnel of what to do. We have some signs here like special airborne isolation, which we only use for highly communicable respiratory diseases, MERS, SARS, or flu. So even though we haven't seen those, our signs are ready to go. They're already pre-printed and could easily be distributed. And all our personnel are taught on how to recognize and use those signs. Dr. Melissa Miller is our molecular diagnostician, associate director of our micro lab. She was hired specifically many, many years ago to develop rapid testing. Our feeling is, in the case of a pandemic, we don't want to be forced to rely on the state of the CDC because they need surge capacity. We would develop our own tests, so we would have our own tests available, and they would need to make the primers available, but we would develop our own tests, as we have with SARS, MERS, and 2009 flu. And then we, of course, would have an algorithm for who gets tested and how that gets reported. This is not simple, it's not easy, and it's not cheap, but UNC Hospitals is committed to doing this and has provided Dr. Miller with sufficient resources to be able to do this. Then, of course, we need to protect our healthcare personnel. We educate them yearly on these issues. We properly train them on the use of personal protective equipment, and they're already trained on how to protect themselves against this. I told you we have a 6-month supply. Influenza immunization is a condition of employment at UNC hospitals, and 97% of our employees have been already immunized with this year's flu. We could potentially use antiviral antibiotics either pre or post-exposure. We've already talked about early detection of patients. We would screen every patient at every visit initially, and then proper isolation, which would be droplet and contact, meaning mask and gloves for our healthcare personnel, potentially airborne isolation if we needed to. And of course, our occupational health department is well equipped to care for any ill healthcare personnel. Now, what are the limits of what we can prepare? Unable to know when a pandemic or outbreak will occur. It's really a question of not when we'll see the next, if we'll see the next one, but when. So we had always planned originally it would start in Asia and move here, but the last one started in Mexico, was already in the United States even before we knew about it. We have a limited surge capacity without altering basic functions. We can turn off elective surgery, but there still have sick patients we need to care about. We're certainly dependent on state and federal actions. We don't have quarantine or isolation powers. That would rely on the state. We don't know what's in the federal stockpile. It's a secret for security reasons, so we can't train our people on how to use whatever ventilators they have because we don't know what they have. We can't train people on what masks to use because, again, we don't know what masks are there. Obviously, we'd have to rely on the state to waive certain legal requirements, such as licensure for retired professionals, use of students beyond their normal capabilities. That would require the state to allow that. And, of course, we would in part want to make our guidelines for access to antivirals, vaccines, and ventilators if necessary. We think that should be done on a statewide basis, not vary between Duke and UNC and Wake. One of the problems for everyone is just-in-time delivery, so the days when there were warehouses down the street full of things are gone. Everybody uses the Walmart model of just-in-time delivery, so if there's any interruption in the chain from South America, Africa, or China in that chain, then we're going to have shortages, and while we can stockpile certain essential things, the hospital uses thousands of medications and materials, and we cannot stockpile all of those, and that's a problem. And the one problem we have not easily figured out is what to do if they close the daycare centers, and what do we do with our employees with young children. Some that have to stay home and take care of them. The best we've been able to come up with is we've developed a buddy system where one worker would come to work, the other would stay home and take care of both their and their buddies' children, and then they'd swap off. But that may not be a perfect solution, but that's probably the biggest thing that we have not been able to solve in terms of limitations. With that, I'll say thank you. This is the human cost of influenza pandemics. Obviously, you can see other pandemics on top. By the way, here's 1918, and of course, here's HIV, sort of the two major pandemics of the last century. And along here, all the other pandemics of influenza, but there's no question that the number of pandemics due to influenza viruses, and particularly if you look at 1918, the potential for a worldwide number of deaths exceed those with any other pandemic we've seen, with the exception of HIV, and otherwise we'd have to go back to something like the Black Plague. And I think all of us will be more than willing to answer questions during the question period later on. Thank you very much.
Hello. I am really honored to be here today. I want to thank Dr. Reimer and the Planning Committee for inviting me. I'm going to talk to you today about best communication practices during outbreaks or pandemics. And I will try not to overlap with too much of what Carrie Lubell said yesterday or Dr. Quinn this morning. We're obviously all in the same field, but I think hopefully will not be too redundant with what they told you. I know we've heard from a lot of virologists and historians and others in the room who, for whom the major role may not be direct communication with the public. But, so I was thinking last night about how do I make this talk relevant to those of you who are not in that role of communicating with the public. And here are my thoughts. So some of you are public health officials, and this will be very relevant. Those of you who are the experts in virology and history and other topics that are so highly relevant will be called upon, inevitably, in the case of a pandemic, to provide interviews. Some of you will be featured on television, and to be interviewed by reporters about your expertise and your thoughts and your predictions. And so I think some of these practices can be relevant in those conversations in making sure that when you have those conversations with the media or whoever it may be, that you are communicating your science as effectively and clearly as you can so that it can have the impact that you really would hope for it to have. So I'm going to start by just showing you this quote from the World Health Organization's 2004 guidelines, and I think it really demonstrates very well how in the last about decade and a half, we've seen the public health community really recognize more and more the importance of good communication in outbreak control. For a little background, I wanted to show you this poster, which I know you've probably already seen because it's on the slide deck that rotates in between our sessions. But it's just one example of the types of communications that were around in 1918. Just to give you a little idea of the communication environment at that time. And so you can see that as well as the medical interventions having really evolved over the last century, our communications have changed quite a bit. You may have also seen a poster about onions as the most effective preventive method for preventing the flu. That was a great example too. Just to tell you a little bit more about some of the communication efforts that occurred, in just one quick example from Minneapolis and St. Paul, Minnesota, telephone operators were on strike there, and at the time, teachers were not working because the schools were closed. So Boy Scouts, teachers, and postal workers were employed to help distribute educational materials to the public. And Boy Scouts would have tacked up posters like this one around town. Teachers actually visited homes to find out if anyone was sick or needed help. So there weren't a whole lot of mass media efforts going on at the time. By contrast, a century later, we have not only 24-hour cable news networks, but SMS text message alert systems that can deliver an emergency message to your back pocket or your hand instantaneously. And we saw a really bad example of that earlier this year in Hawaii with the ballistic missile alert system that erroneously went out to folks living in Hawaii. But that's an example of the kind of instantaneous communication that can reach mass numbers of people. Not only that, but a proliferation of social media channels and outlets that can be used in times of pandemic or outbreak. But just because we have more and faster communication channels doesn't mean the communication will necessarily be better. And there are no shortage of guidelines for how to do this, how to communicate well during outbreaks. This is one example, the WHO Outbreak Communication Handbook for Journalists. Another good one is CDC's Crisis and Emergency Risk Communication Manual, which you can find online. But despite all of those guidelines, we have seen examples in outbreak after outbreak in recent years of failures in communication. And some of these have been written about quite a bit. So, for example, the World Health Organization admitted a failure of communication during the H1N1 pandemic, specifically related to not acknowledging uncertainties and also a lack of institutional transparency about the virus. More recently, during the 2014-2015 Ebola outbreak, CDC encountered negative feedback for initially assuring the American public that US hospitals could contain the epidemic just before 2 nurses became infected with it. And I'll talk a little bit more about that in a minute. The good news is that much has been written about those mistakes, and so we can take those lessons learned, some commonly agreed upon practices from CIRC and the World Health Organization, and then some of our own lessons from outbreaks of H1 influenza, Zika virus, and Ebola virus. And when I say we here, I mean researchers at RTI. I'm not talking about myself in the plural, just to clarify. While this list could be long, in the interest of time and parsimony, I've organized them into 10 broad recommendations. And the first 2 are ones that I think could take place before the outbreak occurs. Not that I think could take place, but that really necessarily must happen before an outbreak occurs. And we've heard a little bit about this from other speakers on the agenda, the importance of conducting some advanced research. This can be very important for multiple purposes. So, eliciting existing belief systems. All the public health professionals in this room know that you cannot craft a message without considering the audience. We know the best message in the world is not going to have any impact if it conflicts with the existing beliefs of your target audience, right? So, and knowledge alone is not sufficient to change behavior. All of our public health theories tell us that. So the first step is always to elicit those beliefs. We also want to describe relevant mental models. And if you're not familiar with that term, mental models are the shortcuts or mental schema that people use to help understand complex systems or processes. And so examples that are relevant in the infectious disease world would be how a vaccine works in the body, how a virus is transmitted. If those mental models are inaccurate, then you can have problems when you're trying to prescribe a behavior. Take this vaccine before the outbreak occurs, because if people believe the vaccine works on a virus that's already in their body, they may believe they don't need to get it until after they are sick. So you can understand why it's important to make sure you understand what those mental models are before you try to develop communications, in case you need to correct any misinformation. Identifying best channels, obviously, for reaching target audiences. I'll talk more about that in a second. And testing your potential messages. That can be a little harder when you don't know where the next outbreak is coming from. But we can talk about some ideas I have about the types of things that could be looked at prior to the epidemic. Dr. Reimer specifically asked me to address the idea about how we write messages about vaccines in a year when the vaccine is not optimally effective. And so I just want to spend a minute on that. And this is where the advanced research comes in, because I don't think we know enough about what people know or understand about how the vaccine process works. And Dr. Quinn's research, I was so happy to see that a little bit earlier with the infographic, where she has started to look at, do people understand the process? Do they understand that some years it's going to be more effective than others? That just because it wasn't as effective this year as it's been in the past, that doesn't mean that you shouldn't get it again in the fall. So we can do more of those kinds of studies, helping them to understand the process. And that's also related to scientific literacy, which I'll talk about a little bit more in a second. A related topic here is vaccine resistance in general. As many of you in the room know, public health professionals, that there are growing pockets of vaccine resistance around the country that have resulted in outbreaks of measles and other illnesses in recent years. There is a lot of research that needs to be done to better understand the motivations for that vaccine resistance. In the past, we saw a lot of that being attributed to links between, now debunked, links between autism and vaccines. More of the research I've been seeing recently suggests that there are other motivations. People don't want to vaccinate their children because they don't want to put anything chemical in their bodies. Or they think, these illnesses are pretty low risk, it's better for my child to develop immunity naturally. So understanding what those motivations are for the vaccine resistance can go a long way to helping us develop messages that can help to move people in the right direction towards immunization and towards seasonal flu vaccines. We need to do that, importantly, before those pockets of resistance grow any more than they have, and to be able to sort of address the different motivations and the different reasons why people are resistant. Okay. And then lastly, just a word about channels in this topic, advanced research. This is where you can find out where to reach your target audience. And this is a statistic from Pew Internet Research recently, and you can see it's kind of surprising, but online news is really catching up in the last few years to TV news in terms of where people are getting their news from. However, this is general public. If you're looking for a more specific audience group, like older Americans, this graph looks quite different, with 82% of older Americans still getting their news from TV compared to only 30% from online. So it's a consideration when designing messages for particular target groups. You need to meet them where they are going to see it. In real estate, you may be familiar with the term location, location, location. In communication, it's exposure, exposure, exposure. No matter how brilliantly crafted your message is, if no one sees it, it's not going to have any impact. Very important. And then just wanted to show you, this is from an analysis of Ebola tweets that we did during the 2014-2015 epidemic. And we just included in this analysis all of the tweets that included a link of any kind. And you can see that a large percentage of those links were to news sources, 61%. This was surprising to us. And that compares to only 5% that were linking to public health or government for information about Ebola. So it just echoes that idea that people really are still depending on news sources, and so it can be important to think about working with journalists, which brings me to number 2. And I know you're probably thinking, oh my God, we're only on number 2, and she said she's got 10 of these. I promise I'm not going to spend nearly as much time on all of them as I am on the first 2, so we will go more quickly. So another step that can be taken in advance is developing a plan to work with journalists, and I think this is really important for a lot of different reasons. But the more you plan in advance and figure out what your strategy is for working with media, the better it's going to go when the time comes to actually have to work with them quickly. Respecting deadlines is really important. If you're delivering messages and information to a journalist 30 minutes before they're going live on the air or have to get their newspaper article out, they're not going to have time to wrap their heads around it. That's where mistakes get made, and they may also be frustrated with you for waiting until the last minute. So knowing what those deadlines are and what their constraints are, and trying to reach them at a time when they can really dive in and spend the time they need to get it right is important. Understanding the importance of newsworthiness is also important. Just because we want people to cover our topic doesn't mean they will. And that can be frustrating. Ebola and other hemorrhagic illnesses are inherently newsworthy because they are sensational, graphic. Lyme disease, not so much. Even though it affects a whole heck of a lot more people, it just isn't as newsworthy for those reasons. You might have heard the old saying, if it bleeds, it leads. It's not just a myth. I went to school for journalism, undergrad. They actually teach it there. So I'm telling you, this is why we saw such an uptick in Ebola news coverage during the 2014-15 epidemic and that fall. And it probably really outpaced what you would expect from some of these other infections. Also remember, the journalists don't know the literature the way you do. We've seen this time after time where a report comes out about linking coffee with some illness, and it makes big headlines, and they don't put it in the context of all the studies that came before that might show conflicting results. So make sure you provide that context, because you can't trust that a reporter is going to have the time or the knowledge to know how to find the literature and do that work. And when you're talking to them, downplay the sensational and hammer home your action points, because that's what you want the takeaway to be, right, for the audience. All right, I'm going to skip to number 3, which is building trust by communicating. And this is one we've heard from some of the other speakers already. Early, often, as transparently as possible. And the early is really important, especially in this day and age with social media, because while it seems really obvious, when an outbreak occurs, our first instinct is to gather more information before we say anything, because we don't want to incite panic, right? But that might backfire if you wait too long, because if it gets out on social media before you've made an official statement, it can look like the government is trying to hide something, and that can undermine your trust, which is going to be problematic as the outbreak unfolds. Addressing uncertainty in an evolving situation. This has also already been talked about a bit, and there are volumes written about how to communicate uncertainty. But I think explaining the reasons for uncertainty can be very helpful. We don't say we don't know how many cases. We say, instead, we are awaiting lab results to confirm some suspected cases. We expect to have that information tomorrow, and then we'll have a better idea of how many cases. We could say numbers have changed because some states submitted revised reports, as opposed to just coming out with revised numbers. And we don't say with authority right out of the gate, the disease is not transmitted through the air. Because if it turns out that it is and you find out later, it looks like you were wrong or you were hiding something. So better to say, at this time, we have not seen any evidence that the disease is transmitted through the air. If that changes, we will update you. As of right now, this is what we know, but the situation may evolve. It can feel unnatural to admit what you don't know, but it will garner you a lot of trust in the long run. Okay, has anybody in the room ever found themselves in an emergency situation? Can I see a show of hands? Okay, so it's a good number of you. So you can probably remember how difficult it is to think clearly when you're in that emergency situation, scared, maybe panicked, and this is very important. It's important, first of all, to express empathy and acknowledge that people might have feelings of fear if the pandemic has already unfolded and people are dying, grief, and other negative emotions that can come in, and to remember that fear can also interfere with people's abilities to process information. So this is where it's especially important to be as clear and concise as you can, because interpreting a complicated message when you are fearful can be even more difficult than it is during times when that anxiety is reduced. And this might be familiar to a lot of people in the room. This is just one example of a a theory that we use to design theory-based messages, a theory of reasoned action. I was fortunate enough to have been partially trained by Dr. Fishbein, and so this is one that's near and dear to my heart. But I think the important point here is that this is where we see the beliefs, and we know that beliefs are very predictive of intentions to engage in the behavior, but also the social norms that Dr. Quinn mentioned earlier, and people's self-efficacy, their ability to feel that they do have control and that they can take action in the situation. So making sure that your recommended actions are theoretically driven is important. And that comes in with the advanced research too, because you have to look at which of these theories is most relevant, what's driving your behavior, and which kind of messages are most likely to influence behavior. That's all work that can be done in advance. And especially because if we believe a pandemic is coming from, well, it will come from flu, we know that even though we don't know which strain it is or when it's going to happen, vaccines and antivirals are going to be two really important pieces of the puzzle, as well as school closures and some other things. So we can do research on all of those recommended behaviors now. We don't have to wait until we find out which disease is going to be causing or which strain is causing the pandemic. Okay, in this picture, what you don't see is knowledge, and I think it's important to remember that. I said earlier, knowledge is not sufficient to change behavior, but it is necessary. If people don't have the awareness of how the virus is transmitted, they're not going to be able to adequately protect themselves. So you can't forget about knowledge. And we have seen in our own research in a couple of recent epidemics that awareness can be low, even when you think it shouldn't be. For example, during Ebola, we did the content analysis, which showed a lot of news coverage, but awareness of how the virus was transmitted was still relatively low. And so you have to make sure that the facts are there too, that they're getting that clear information about transmission routes and other important details before trying to influence the behavior. Okay, I'm running out. So I'm going to go really quickly. No reason for messages to be full of scientific jargon. There are plenty of resources to help create clear, concise messages. Also important here is thinking about people's health literacy, scientific literacy. Do they understand a difference between antivirals and vaccines? We don't know in some cases. So those are things that can be explored in advance. Remember that percentages and numbers are still hard for some people to interpret. And context is super important. We can say we're projecting 25,000 deaths from this outbreak, and that can have a pretty significant reaction. If you put it in the context of how many people are likely to die of the seasonal flu, then it has a kind of a different meaning. Remember, communication is a two-way street. We're not shouting our message at the public and hoping that they do something. We have to also provide outlets for them to get their questions answered and to provide feedback. And so these are some examples. Carrie provided a good example yesterday with the CDC info line, and that's how CDC tries to keep those lines of communication open. Running out of time here, so I'm going to wrap it up. Just quickly, monitoring social media is really important. This is obviously because you can identify pockets of negative sentiment toward vaccines, for example. You can explore reach of your messages, figure out how many people you're reaching. You could also identify people who are influencers if you wanted to get some community folks involved in helping get your message out. It's a good way to reach those people. Provide a crude sense of sentiment valence. And perhaps most importantly, identify any misinformation that's out there. We've talked about fake news a little bit. This is actually a real example from Ebola in Iowa. The Iowa State Department of Health was monitoring social media, and they saw these messages and actually intervened to make sure that they cleared up the myth that Ebola had actually traveled to Iowa. Other issues: undermining trust in government, stigmatization of survivors, conspiracy theory, all kinds of misinformation that can be out there. And my last is remembering that the public's attention is ephemeral. It is not likely that you're going to sustain attention throughout the course of the pandemic. This is just a graph that shows media coverage, AP-Wire coverage of Zika virus, and it's tracking with Google searches and Twitter messages during the Zika in 3 different countries, US, Brazil, and Guatemala. And so you can see there's a spike in Google searches and Twitter as a function of news coverage, and then it drops off pretty quickly, which means you lose people's attention pretty fast. So here, important to note that wear out can occur. You want to garner attention when it matters most, so don't overhype prior to an epidemic. In conclusion, we don't know when or from where the next outbreak will occur, and we know no two outbreaks are identical, so it can be hard to plan some of the details. But despite planning, an outbreak will require people to think on their feet, and having some of these tools in your pocket before that happens, I think, can really help to ensure that your message is heard, first and foremost, exposure, and that it has the desired impact when you do have to get that crucial information out. Just want to acknowledge some of my colleagues, and I am happy to answer any questions when we get to the question and answer period.
Okay, resetting my timer and go. I already started. That's not fair. Okay, I'm Zach Moore. I'm the state epidemiologist in North Carolina. I wanted to thank Dean Reimer, the rest of the planning committee for such an enlightening set of sessions. I've really enjoyed it. I did want to acknowledge that I don't have financial acknowledgments, but I am not a virologist. I've done no antiviral or vaccine research, so I'm in those regards not a flu expert. I do play one on TV when David Weber's unavailable during the season and somebody wants something. But I have been in public health, applied public health, working with many different flu seasons and one flu pandemic. So that's the perspective that I want to bring. I also want to beg your indulgence. Some of my slides will look familiar. It's late in the program. Sorry, you got the last couple of them, I think. But, you pointed out redundancy and how important that is in hospitals, and it's important in conferences as well. Good didactic tool. So I'm just going to start with my big points. I have two big points that I want to get across. Got a picture for each just to make them stick in your memory. The first one is just the importance of state and local public health in responding to pandemics. This is really where the rubber meets the road in many regards. We rely heavily on CDC and in some cases WHO for wonderful guidance. But when it comes to implementing surveillance, implementing prevention, that happens to a large degree at the state and local level, and I'll talk about that. The second one, and Dr. Frieden actually alluded to this too, is that it's not about just having a plan and having it and exercising it and then putting it on a shelf. We need to have public health staff and public health departments that are experienced with responding to health emergencies every day, maybe not every day, but they're familiar with it. So it's the lower down you go, or the closer to the, from federal to state to local, it's the same people that are going to be responding, whether it's a flu pandemic or an outbreak of E. coli or a large sewage release. And so those kinds of, having that capacity in place is what's going to help you. If you don't have that infrastructure and that experience, there's no amount of planning, no amount of tabletops, no amount of just-in-time funding that's going to make you successful in responding to a pandemic. So those are the 2 points. Now we're done. It's just for fun from here on out. You've seen a lot of this one. No one got to this one, so I'm pleased. The impact of the 1918 pandemic. This was Dr. Jones speaking at the meeting of our North Carolina Medical Society the year after the pandemic. And he said, "It's beyond the power of man to adequately express, even in part, that which has taken place since last we gathered here. Never before has a year so pregnant with momentous results passed across the dial of time." So people were very eloquent in those days, which I liked when I was reading through all these historical accounts. You've definitely seen this. I won't dwell on it. This one's slightly different, but it just makes the point that pandemics have the capacity to devastate a population and to dwarf all the other communicable disease things that we work so hard to prevent, which is why this requires so much of our attention and why it's good for us to go back and consider the experience of 1918 often. Of course, we've come a long way since then, and I have a little bit of the then and now thing, as most of our sessions have. In terms of our understanding back then, from the Charlotte Medical Journal, the cause of the disease, it's an appalling, if not paralyzing mystery. You can only imagine how that feels. We've had some mystery illnesses too, never on that scale. Now, of course, we know a lot. We have the full sequence, we know all the proteins, we know the functions, so we've come a long way. But I think humility is important. And here's a quote from Edward Wood in the Charlotte Medical Journal. I have a couple from him. He was a good one. To us, our own time is the wisest of all ages in things medical. Every age has had the same inflated ideas as to the importance of its own accomplishments. And we are certainly no different in our time, so it's important, in the words of Kendrick Lamar, sit down, be humble, remember that we've come a long way, but we have a long way to go, and we would all be very foolish to think that we are truly prepared for the next pandemic and that, you know, we have our stockpile, we got our plan, we're good to go. Recognize that flu constantly surprises us. Okay, so public health infrastructure, a little bit of the then and now, and I will focus on state and local here, but this is our state health director, actually W.S. Rankin in 1918, on October 12th, sent this telegram to the head of the U.S. Public Health Service. Kannapolis, three doctors, 2,000 cases of influenza, doctors about exhausted, condition urgent and serious. Please have 3 nurses and 2 doctors sent at the earliest possible moment. Like that's going to help. But even that meager request was not met, and shortly afterwards he wrote, "In less than a week, the U.S. Public Health Service and the Red Cross, swamped with appeals from all parts of the country for doctors and nurses, threw up their hands in despair and admitted their inability to supply the urgent appeals for help." So thank you to our CDC colleagues. I've never gotten this response, any call to CDC, so we have come a long way in terms of infrastructure. We had no World Health Organization. We had no CDC. We actually, the predecessor to the agency that I'm now chief of, the Bureau of Epidemiology, had just been started the year before, and there were, you know, not many people in it. I have to say, North Carolina is a leader in both state and especially local public health. We did have the first local health departments in the country. They were around at this time, but they were focused on hookworm, malaria, and didn't have a lot to offer in terms of dealing with this type of thing. So now we have this coordinated system that operates at the local level, state, federal, and global. We have some of our local health department partners here, which I'm grateful for, and we do routine planning and exercising. So we really have come a long way in that regard. And when we talk about preparing for a pandemic, there's several ways that you could categorize the sort of buckets of work that go into that, and this is just one example, happens to be how our state plan is organized. I'm just going to go over it high level. I'm not going to stand here and tell you I know what's in our pandemic plan in any great detail. It's being revised, but these are the sort of ideas of what we build into that. First is incident management, which doesn't sound very sexy, but there are a lot of agencies and people that will need to be involved in a pandemic response. There's everything from the hospitals and the hospital preparedness program to schools, to businesses, to agriculture. Coordinating that type of thing is something that really needs a lot of forethought and a lot of practice, and that's why, you know, we exercise this when we respond to other types of situations. You really don't want to be meeting your partners for the first time during a flu pandemic. Surveillance, epi, and lab activities. I will touch on this in a little more detail. This is where I've spent most of my time related to flu, and so something that's near and dear to my heart. Medical countermeasures we've heard a lot about, and I'll touch on briefly. There's the sort of hard material, there's the vaccines, the antivirals, the devices. I think it's been well acknowledged that you can't buy your way out of a flu pandemic, and it's not just about having the supplies, but this is an important piece that I'll touch on a bit. Non-pharmaceutical interventions we've also heard about. This is the community mitigations, this is the infection prevention, and so I'll touch on this one as well. And I will not touch on the last couple here, medical response and surge capacity. I think Dr. Weber did a very nice job of explaining from a UNC perspective how they are preparing for surge. It's important to recognize that at the state level we have all of our hospitals are arranged into regional healthcare coalitions under the umbrella of our hospital preparedness program and our Office of Emergency Medical Services. So there's sort of a state component for assisting hospitals with that type of surge capacity. Unfortunately, this also includes mass fatality planning, which we're engaged in regularly, and other sort of surge concerns. And then communications and public information, which Dr. Kelly just spoke to, and I think I won't get into that. So I said you've seen my slides before, so I'm sorry, but the CDC has given us at the state and local level some very nice frameworks for planning, and this is one that's really important. This is the intervals, the CDC intervals. So I'll describe just a little bit more. Investigation is when you have novel flu viruses, which there always are. Recognition is when some of those viruses start being transmissible person to person. So you have a little bit more increase in cases. Initiation is when one becomes able to transmit in a sustained way from person to person. Once that's happened, it's often running to a peak of a pandemic and then preparing for the next waves. So this really helps us, and we structure our plans according to this, because the things that, from a surveillance perspective, in these early phases, we're going to focus a lot on identifying individual cases, and we're going to investigate them. Our local health departments are going to track them down. They're going to find their contacts. They're going to issue isolation orders. They're going to issue quarantine orders, that type of thing. If we want to do school closure, if that's an option, we need to, as we've heard, get that going here in the initiation, because once we're up to the peak, it's too late. Once we get up here, all of our measures are different. So our plans are going to reflect things like we're not going to do individual case investigations anymore. We're going to switch to syndromic surveillance to understand the trends and understand the severity and who's being hit hardest. We are probably not going to be able to really enforce individual isolation and quarantine orders. We're going to move more towards focusing on mass gatherings, focusing on surge, that type of thing. So this is very helpful in structuring. And this is the other one Dr. Weber alluded to earlier, which presents pandemics. It's a way of measuring them in terms of how transmissible they are and also how severe they are. So this is 1918 up here. This is 2009, and you can see this little oval is in the realm of seasonal influenza, I guess badness, for lack of a better term. So the things that we might do if we had a 1918 type situation are very different than those that we would do in 2009, in terms of canceling schools, in terms of canceling mass gatherings. That's all very appropriate over here, probably not so appropriate for one that's more in line with what we see with normal seasonal flu. And so there's a whole nice way of making these assessments really early from our first few cases and then going back and reassessing and targeting our strategies. So those are the kind of frameworks we have to work with. What do we have to offer at the state and local public health levels? The first one is, of course, capacity and infrastructure. We have health departments in all 100 counties in North Carolina. Same is true in one way or another all across the state. We have immunization programs at those health departments. We have preparedness coordinators, at least one of whom is here in the audience, in those health departments. We have communicable disease nurses. We have laboratory staff. So we do have an infrastructure that's nothing like what existed in 1918. And at the state level, of course, we have our State Laboratory of Public Health, our preparedness program. We have expertise in all these areas. Knowledge and trust of communities, that's a huge one because, again, implementation is going to depend on understanding your community and making something work. You're not going to get school closure if you don't know that local educational authority and have their trust that what you're telling them is the right thing to do. So it's really down to those local relationships. Coordination with partners. Again, you really don't want to be meeting new people during a pandemic. You want to have those relationships established, and that's really a big focus with all of our local health departments and with our support to them, is that they engage regularly with these partners, whether that's measles exposure in Wake County, a whooping cough outbreak that we have going on right now. It's hopefully ending in Henderson County, or a large sewage release in Catawba County. You're engaging with your emergency management partners. You're engaging with potentially your law enforcement, potentially all these other partners. So those relationships exist. They're not just on paper. And then lastly, but certainly not least, this is where the legal authorities for responding to a pandemic, and David alluded to this too. The CDC, unless you're on a cruise ship or coming in on an international flight, they really don't have jurisdiction over you. So the authority to implement a quarantine or implement an isolation or take these other measures really lies with the state and local health departments and health directors in most cases. So that's very important for response. Okay, surveillance I said I would touch on. This is my then and now slide. Dr. Bola was the health director in Winston-Salem. He'd asked physicians to report all cases of influenza for inclusion in his weekly report. It's amazing to me how good the surveillance was. I know it's very limited, but it's amazing how, when you see, even going back to the bubonic plague, how well they tracked mortality with these sort of very basic things. But now we have year-round tracking. We have virologic, syndromic data. I'll show you just a sampling of what we do here on the state level. I'm sure this is totally familiar to all of you because you read our weekly flu reports at flu.nc.gov. This is our current season in red here, showing flu-like illness and how it compared to the previous 2 seasons. Again, in a pandemic, this would be and was in 2009 critical for helping us understand where we were in the trajectory of this and understand how severe it was, what proportion of these end up getting admitted, et cetera. We do have certain mandatory reports that doctors are required by law to report to us. In North Carolina, I think we're the only state that has all flu deaths reportable. Most states have pediatric only. We have all. We also have novel flu cases reportable, so that would be vitally important early in a pandemic that we'd be able to hear about those cases and track them. And this is deaths from this current season. I think as of yesterday, we were up to 346. And this is actually a really useful communications tool because this gets a lot of coverage every week and helps keep in people's minds that it's not always a mild illness. And then we're part of a global influenza virologic surveillance system. The specimens we collect and send to our state lab colleagues get characterized. We could find a novel one if it existed. We could do a lot of other things shown here. Look at vaccine match, look at antiviral resistance, which is always a worrisome concern, and find those viruses that have pandemic potential. Along those lines, I'm surprised no one has shown this slide, although it's not a very attractive or engaging slide, so maybe that's why. We'll find out. But this is another CDC framework, the Influenza Risk Assessment Tool. These are current novel influenza viruses globally that we're monitoring and looking at in terms of impact and likelihood of emergence. So we're tracking, these 2 up here, that's H7N9 in China. So this really helps us keep track of what's going on, and we can start formulating vaccines against these, which we do. Of course, as we found with 2009, sometimes it's these ones down here that end up causing trouble that we weren't really watching. But this is a great way for us to keep track globally. Flu vaccines, of course, were not available back then. Now we have these wonderful vaccines. They do prevent millions of infections each year. Of course, effectiveness could be better. We heard wonderful presentations about this. And there are delays, so that if we had a new virus, we'd be looking, the planning estimate is 4 to 6 months before we could get it out there. So what do we do at the state and local level? Well, this is the Wake County Health Department in 2009 with the line that actually went around the corner. This is only possible because the Wake County Health Department runs a vaccine clinic all the time. They know how to receive vaccine, store vaccine, administer vaccine, and our immunization branch supports them in this. So this is what's needed to be able to spring into action when and if there is a vaccine available and get it out where it needs to be. You've seen all the onions and the flu treatment slides. So, of course, in terms of antivirals, that's another major piece of our state and local preparedness. We do have effective antivirals, and Dr. Hayden spoke to us yesterday. I was actually very encouraged to hear some of the newer ones that are further along than I had thought. We only have 1 class that's currently approved, which is not where you want to be for a rapidly mutating RNA virus. In terms of supportive care, I like this quote again from Edward Wood. Cold rectal irrigations prove to be a useful antipyretic, that's for fever, and prolonged hot irrigations of the auditory meatus, the ear canal, for earaches. So that's kind of where we were then. Sunshine was a popular idea too. And now we do have all these other forms of support to help get people through. Notably, we also have the antibiotics for treatment of secondary bacterial infections. So again, this is a major part of our ongoing work, and we at the state level do coordinate the Strategic National Stockpile for North Carolina. We staff the receiving sites, the points of distribution with our local health departments, I should add, because that's really a lot of their staff. And there's a lot of planning and things that go along with this. It's really not about just the supplies. I think you've seen the non-pharmaceutical interventions. What I like is how similar these are to our current messages. The fonts have changed and we have color now, but otherwise it's pretty similar. Personal protective measures, social distancing, I should add infection prevention, closures, isolation, and quarantine. So those are all very similar to what we would do today. You know, the details depend on what's coming our way, and we do have a lot better ability to understand transmission, but the concepts are the same. Here's an example of a quarantine order we have ready to go for our health directors in case this happens. So I just want to wrap up by shifting my focus away from pandemic influenza, and Dr. Weber stole this too. But I just would like to remind us all during this conference about how bad pandemics are, that seasonal flu is pretty darn bad too. Up to 35 million cases, hundreds of thousands of hospitalizations. This is just between 2010 and 2016, where we didn't really even have a season as bad as the last one. And tens of thousands of deaths, which brings me to my last quote. Influenza brings to light a strange mental makeup of humanity. If a few thousand men are killed in battle, the whole nation goes into mourning. While within the last year, nearly 500,000 of lives have been lost through influenza without the least show of emotion. And it sort of gets to what Dr. LaBelle mentioned about the familiar and the exotic and what we focus on. And if this is true for pandemics, it's more so with seasonal flu. And I hope that all the wonderful science and things that we've heard about will help us reach a point where this is no longer considered just a normal part of life. And with that, I will wrap it up and we can move into the questions.